Well, good morning, everybody. Katia too told me exactly 7:30, so that's what we're doing today. Thank you all for joining us for Winship Grand Rounds this morning. If you're an Emory Healthcare or Emory University employee and you'd like to receive a CME credit, you can do that today. The access code is 603810. Should be found in the chat feature at the bottom of the screen. And if there are any issues or trouble, please send Katia Fofana an email, or you can reach her in the chat feature. Okay. So you may know I'm not an oncologist, but I've worked really closely with the Winship for all my years at Emory, and it's really a great opportunity to come. Thanks to my dear friend and co-investigator Tunji for reaching out and for inviting me. I've actually worked so closely with you guys, I'm now getting job offers to join oncology divisions. And I think to myself, do they know I'm an interventional endoscopist? But this is the great reputation of the Winship. It's truly my great honor to introduce our speaker for today, Dr. Shanthi Srinivasan. Dr. Srinivasan is my friend, my colleague, and also the chief of the Division of Digestive Diseases here at Emory. I've had a great many chiefs in 5 different institutions over the years, and it is very rare to find a chief that is so invested and who cares so much about every faculty member. She's been the division chief just for several years now, but has had a transformative effect on our division. She created a leadership council trying to get the input of every person in our division. She created faculty awards, and she has sought to champion all the causes of our faculty, from the colon cancer walk, and thank you all for Winship being a big part of that, to a wellness symposium in the pandemic when we really needed it, and to the very first division-wide CME course in gastroenterology. One of my colleagues, in fact, just texted me and said that what we have is genuinely caring leadership in the division, and that couldn't be more true. Dr. Srinivasan joined the faculty at Emory in 2003 and now serves as the R. Bruce Logue Chair in Digestive Diseases and is a full professor of medicine. Her clinical interest is in gastrointestinal motility disorders with a particular focus on diabetes and its effect on gastrointestinal motility. So please join me in a very warm welcome for Dr. Srinivasan today for her talk, Connections Beyond Digestion, the Gut-Brain Axis in Colorectal Cancer.
So thank you, Field, for your very kind words and introduction. And thank you to Tunji for inviting me to give this talk, and to the entire Winship Grand Rounds committee. Thank you, Kariatu, for all the arrangements. So today, over the next 45 minutes or so, I'd like to talk to you about something different as it relates to colorectal cancer, and that's the gut-brain axis and how nerves, or what we can call cancer neuroscience. I want to introduce that concept and how others are studying this in the lab, as well as some of the work in my laboratory related to the enteric nervous system and how it may be applied to colon cancer pathophysiology. To advance is just sorry, just click. Yeah. So just an outline of my talk. I'm going to spend a few minutes on the prevalence and incidence of colon cancer. I'll talk a little bit about screening for colon cancer. So that'll be the first maybe 20 minutes of the talk. But then the remaining, I'm going to talk about the pathophysiology of colon cancer, but focusing, as I mentioned, on the gut-brain axis, and then finish up with the enteric nervous system and how it relates to colon cancer. So as you know, can the top be, sorry. So as you know, colorectal cancer is one of the 3rd leading causes for new cases of cancer, as well as a 3rd leading cause for death related to cancer. And both with a slightly higher prevalence in males compared to females, And I should also mention there is a higher racial distribution in terms of a higher prevalence in African American males compared to other racial groups. Now, fortunately, the annual rates of colorectal cancer has been steadily coming down, and we think this is because of early detection, screening, and various reasons leading to a reduction in the rates new cases of colorectal cancer. However, as you know, this is this is a disease of, as one gets older, there is a much higher incidence of colorectal cancer. One thing I should point out is that we are now starting to see advanced adenomas and colorectal cancer at a much younger age group, starting at age 40, from the 40 to 50 years old, which is one of the reasons the screening guidelines are, as I'm going to show you over the next several slides. So as we know, 75% of CRC, colorectal cancer, is sporadic, and then we have about 15% familial, and then various genetic syndromes like HNPCC, familial adenomatous polyposis syndrome. There's a higher prevalence of cancer in the inflammatory bowel disease patients. And so this is the sort of underlying distribution of causes for colorectal cancer. And we all know the basic, hypothesis of the adenoma carcinoma sequence. This was described by Bert Vogelstein several years ago. And so what this demonstrates is the normal intestinal epithelium in the presence of several accumulative mutations, such as those described here, APC, KRAS, P53, SMAD. There's development from normal intestinal epithelial cells to the adenoma as depicted here, and ultimately carcinoma. And this is shown in the endoscopic views here from pedunculated polyps and ultimately to cancer. So this is the known sequence and a big basis of the underlying pathophysiology of colon cancer. I wanted to spend a few minutes on the guidelines. As you know, various societies have put out guidelines for screening for colon cancer. I'm just going to cover a couple. Fortunately, all of them sort of have fairly similar recommendations. So I'll start with the ACS, American Cancer Society recommendation, where they recommend the screening age to be 45. And this, as I mentioned before, is due to the rising incidence of colorectal cancer in the age less than 50, and this has been done based on several modeling studies that show the benefit of starting screening at age 45. Then the USPSTF recommendation is again to screen average risk men and women starting at the age of 45. Here, the recommendation is a grade B recommendation. However, we as advise our primary care physicians to start screening at the age of 45. And then finally, I just wanted to comment on the key screening tests that PCPs are now employing. The fecal immunochemical test. What's nice about it is it's just one sample. It's immunochemically, it's detecting, human blood. So it's, there's no dietary or medication restrictions, and it has, as I'll show on the next slide, its specificity and sensitivity is about 90%. So this is for a performance of a one-time FIT test. There's also, as you know, the multi-target stool DNA test that includes both a fecal immunochemical test as well as testing for various mutations like KRAS, NDRG4, BMP3. So these are some of the mutations. And as you can see, the sensitivity and specificity is demonstrated there with a 92% sensitivity. In this particular study, the FIT test had a little bit lower sensitivity of 73%. So limitations of the multi-target DNA testing is that it's, I'm just going to highlight the part here where the cost is, much higher. However, we currently are recommending the FIT test or the multi-target, DNA detection test. I wanted to spend just a couple minutes on the Nordic study. Just to, people have been talking about the benefit of colonoscopy for screening for colon cancer. And so I think no talk would be complete without, referencing this study and discussing what was, its conclusions and why we still recommend that colonoscopy is one of the best tests for screening for colon cancer. So as you can see here, the Nordic trial, it was a randomized controlled trial with almost 85,000 adults in the age group of 55 to 64. And this was done in Poland, Norway, and Sweden. And the participants were randomized to, 1-to-2 ratio to the intervention group, which is a one-time invitation to undergo screening colonoscopy, or the usual care group that did not undergo any cancer screening. So I think the key term here that's important to know is that this was like an invitation to undergo screening colonoscopy. What the study, only 42% the adherence of colonoscopy was seen, and the CRC incidence risk reduction was about 18%. Unfortunately, this study found no difference in the colorectal cancer mortality or all-cause mortality between the two groups, the test and the intervention group. But what's important to note is that this was an invitation to do the procedure. And the biggest thing that we need to take from the study is that no test is good if it's not performed. So adherence was key here. A couple of other things, the quality of colonoscopy. We have a metric called adenoma detection rate. And in this particular study, the adenoma detection rate was less than 25% for many of the endoscopists. So that was of concern. And the final takeaway message from this is that we should not discourage patients, and that screening for colon cancer, colonoscopy is the gold standard. So, and then just one other slide I wanted to present before I move on to the next part of the talk, just to highlight the importance of, winning examples of improving adherence. Both the Kaiser Permanente, they have demonstrated, using FIT screening, the effectiveness of FIT screening, as well as at the VA hospital where I practice. There's a really good screening program where there's, successful FIT-based screening, as well as, conversion to colonoscopy. So both of these very important, to show the importance of colon cancer screening, whether it's through stool testing or colonoscopy. So with that, I'm going to move on to the second part of the talk, where I want to talk a little bit about the gut-brain axis. So I'm going to define first what the gut-brain axis is. As many of you know, the gastrointestinal tract is innervated by nerves, both externally, what we call the parasympathetic and sympathetic innervation, as well as internally, the enteric nervous system. And it's demonstrated on this cartoon here, the interaction between the environment within the lumen of the gut, including the microbiota, the microbial metabolites. There are several neuroactive molecules, short-chain fatty acids. They all can communicate with the brain through various methods, through the intestinal lining, through the nervous system within the intestine, the enteric nervous system that I'm going to talk a little bit more about. And then finally, what we call the extrinsic nervous system, the parasympathetic and sympathetic nerves. Now, I teach a neuroscience class, and in that I explain to the students the best way we can, understand the parasympathetic and sympathetic innervation. For example, when we enter a restaurant and we have the ambience, the smell, that's actually the parasympathetic system that's getting activated and making us, starting to secrete our gastric juices, getting the gastric motility, activated. So it's the vagus nerve, which is the biggest sort of parasympathetic innervation to the intestine, that leads to this control. So there's a big interaction between the brain and the gut, and that gut-brain axis works both ways. So the what's in the gut, so let's say our stomach is, we've just eaten, we're full, that can influence satiety, so that can influence the brain, as well as the brain can then in many ways influence the gut motility. So a good example is when we're anxious, we're going to take a test or something, then that anxiety leads to increased GI motility. So I spend a little bit of time on this just to say that there's a bidirectional communication between the gut and the brain, and that is what is called the gut-brain axis. Now, for us in the GI field, we study this gut-brain axis a lot in the context of gastrointestinal motility. But today I'm going to show you some examples of how the gut-brain axis can actually be involved in colon cancer pathophysiology. And so before I do that, I want to tell you a little bit about the enteric nervous system. Now, the enteric nervous system is called the intrinsic nervous system of the gastrointestinal tract. So many of you may or may not be aware that we have this large nervous system within our GI tract, which actually has as many neurons as the spinal cord. And a scientist by the name of Mike Gershon, he called this nervous system the second brain. So one important thing is, if we take a piece of our intestine and just take it out of the body and put it in a buffer, the entire intestine can work independently. So I give you that example to say that the enteric nervous system can actually work. It's an independent nervous system. However, it is influenced by the extrinsic nerves, like the example I gave you of the vagus nerve. Now, a little bit about what does the ENS do? It controls sensation. So for example, if we put a lot of air in the colon when we're doing a colonoscopy, the initial sensations that are perceived are from the enteric nervous system. And then the ENS is important for motility through motor neurons. Interneurons help in connecting, and the coordinated process of peristalsis. And then very important is the communication with what the enteroendocrine cells that really help in, satiety, things like that, obesity. And I won't have much time today to talk about the EEC cells, but this is just a cartoon that shows where the enteric nervous system is located. There are two plexi, the submucosal plexus that's drawn here, and then there's an external, the myenteric plexus that's sandwiched between the two muscle layers of the intestine, and that's more related to motor control. So all this just to describe the anatomy of the enteric nervous system. But then you may ask, so I know this is a busy slide, but I wanted to highlight how recently there's a lot of interest in the gut-brain interface and how it can help to combat gastrointestinal cancer. I guess maybe I should clarify a little bit, not a lot of interest, but there's recent interest. And I picked this paper because it's in the JCI, published in 2021. And I want to spend a few minutes to go through, how the gut-brain interface can actually influence gastrointestinal cancer. And you can almost view it as an inside out, mechanism starting all the way from the gut lumen. As we know, what we put within the gut lumen, which includes diet and the microbiome and microbial metabolites, can all influence the intestinal epithelium here. And these cells are the beginning of, colon cancer. So I'm just going to walk through all the different ways in which this gut-brain, axis can influence colon cancer. First of all, the cancer cells can actually release nerve growth factor. I think I like to use the analogy that within a cancerous tissue, we know that there's attraction and vascular invasion. similarly, I think the cancer cells are attracting the nerve fibers into the tumor. Along with that, the nerves can actually serve as a pathway for tumor spread. And I'm going to show you some published work related to how perineural invasion can actually lead to cancer spread. Finally, there's vagal innervation. The extrinsic innervation can actually stimulate cancer progression. And this is through the neurotransmitters that are released, neurotransmitters such as acetylcholine. So definitely neurotransmitters are another way to influence the epithelial cells. I mentioned gut microbiome. So the fecal bile acids can actually modulate both cancer function as well as immune function. Again, immunocyte function can be modulated by the neurotransmitters, and I'll show you some examples of these in the subsequent slides. We know the intestinal barrier is critical in terms of what it allows the microorganisms or the microbial products to influence and modulate immune function and neural function. Finally, the enteroendocrine cells, as I mentioned before, they can be influenced by the neurotransmitters. The cancer cells itself have receptors for neurotransmitters as well as neuroactive biomolecules. And then finally, the subepithelial telocytes, they can actually give a pro-proliferative signal to the intestinal stem cells. So I know it's a lot of different ways, but the bottom line here is that there's almost a bidirectional crosstalk between the intestinal epithelial cells and the nerve cells, neurons that are present within the intestine, as well as the extrinsic neuron, to influence the growth of the epithelial cells here. And this entire axis is depicted here. And this is a nice JCI article. This same article shows in more detail what are the different neurotransmitters that can actually influence the epithelial function, barrier, proliferation. And I'll just highlight a few. Serotonin is very important in terms of influencing GI motility, but can also influence GI cancer cell proliferation. Acetylcholine is a big one through both muscarinic and nicotinic receptors. We have various neurotrophic factors like NGF, GDNF, BDNF that all influence. So this is just a cartoon to show that really the neural glial cells are present in the tumor microenvironment and can influence GI cancer cell growth. Another cartoon just showing that all of these signaling pathways, including the PI3 kinase pathway, the MAP kinase pathway through ERK, can actually influence cancer. Similar to angiogenesis, the neural innervation can actually help in proliferation and cancer pathophysiology. Just going into a little more depth into the tumor microenvironment, the stromal cells can produce neural-related factors. The tumor-associated macrophages, they play a role in the beta-adrenergic signaling pathway, and they can actually accelerate angiogenesis and attract tumor cells. I already mentioned neurotrophic factors, and I think the importance of all of these is that these can then be used as targets for therapy to prevent progression of colon cancer. A little more detail on one neurotransmitter, acetylcholine, and its receptor. There are two types of receptors for acetylcholine, muscarinic and nicotinic receptor. And again, in this JCI article, they talk about how the M3 muscarinic receptor actually has been demonstrated to play roles in gastric adenocarcinoma, pancreatic adenocarcinoma, as well as colorectal cancer. As you can see, whether the transmitter is from extrinsic nerves like the vagus nerve or intrinsic from the enteric nervous system, it can ultimately influence the epithelial cell proliferation. And so these are all potential targets for therapy for colon cancer. So a big aspect of this is actually the neuroimmune interaction. As we know, just as the gut has a lot of neural innervation, the immune cells in the gut form a large population, And the immune organs are innervated by nerves. They have both adrenergic and cholinergic receptors, and the both acetylcholine as well as cytokines. There's again a bidirectional talk as depicted here of influencing the immune cells. And we know how important the immune cells are in regulation of cancer, including colon cancer. The vagus has been known to have an anti-inflammatory role also, and that actually may play a role in cancer metastasis. And then finally, the beta adrenergic receptor agonist can suppress NK cell activity and thereby potentiate metastasis. So all of this just to show that these neurotrophic factors can influence not just the epithelial cells directly, but also the immune regulation of the epithelial cells and the cancer pathogenesis, and thereby demonstrating the importance of the neuroimmune interaction. I want to highlight here Pulmira Nurgali. She is at Victoria University in Australia. And actually, she gave me a few of these slides. Her major focus is the role of neurotrophic factors in colon cancer. Another thing I wanted to demonstrate is focusing more on the enteric nervous system now. This is from a group in Poland. And what you're looking at here is a cross-section of the colon. And this is a normal ganglion. The way we can tell it's, it has the normal sort of spindle-shaped architecture here. And this green staining is actually a stain for a neural marker called beta-3 tubulin. And as you actually here, it's PGP 9.5. That's a neural marker. And what you can see is in the cancer, in this colon cancer cross-section, there is loss of neurons. There's the intensity of the green staining is reduced. There's a change in architecture. So we know that having cancer, there is a morphological change in the ENS. And I think moving on to show how can the enteric nervous system really contribute to pathogenesis of colorectal cancer. This was a nice paper in EMBO Reports in 2021, where they showed the NDRG4, which we know is a marker, has been used as a marker in colon cancer. When that is lost in the enteric neurons, it promotes colorectal cancer. And that's demonstrated in this graph here, where the size of adenomas, both in the small intestine and the colon, was larger when this gene is knocked out. This gene knocked out within the enteric nervous system, and that's also depicted with some examples here, where the size of the adenomas are larger. So again, to show that there is some regulation from the nervous system to the colonic epithelial cells that's predisposing to cancer. So moving on, so far I've talked about the sort of influence of nerves on the epithelial cells and immune cells. But this was a very interesting paper published in 2018 in one of our premier GI journals, CMGH. And what they showed was that the colorectal cancer cells can actually adhere and move along the neurons, and this can lead to a metastasis. So this is a very interesting concept where the epithelial cells depicted here are migrating along the neurons, and important molecules like N-cadherin are important for this attachment and then transit along the neurons, and this can then help in metastasis. So it's one aspect of the ENS that may be contributing to metastasis. And in this same paper, they showed that within the cancer, within the colon cancer, there is evidence of this. The green stain represents neurons. So actually, the tumor, the ENS, enteric neurons, are part of the tumor microenvironment, as I mentioned before. And then in the same study, they nicely showed that if they took the enteric neurons and epithelial cells, intestinal epithelial cells, and co-cultured them, they saw how the epithelial cells, which are demonstrated here with a GFP marker, really adhere to the neural network, and that supports their hypothesis that yes, these can almost serve like tracks or conduits for metastasis. Moving on to the next aspect of where the enteric neurons may be involved in colon cancer and its treatment, the same person I mentioned, Kulmira Nurgali, she works on the effects of various cancer therapies on enteric neurons. And I know there's a lot of information on this slide, but the main take-home point here is that the cancer chemotherapy can result in loss of enteric neurons, as is demonstrated here, as well as a significant amount of oxidative stress. There is ENS-related GI dysfunction, and we know many patients on cancer with therapy have constipation, present with quite severe constipation, and one of the reasons can be the effects on the enteric nervous system. And again, another follow-up, this is also from Dr. Nurgali, where there is further evidence of damage to the enteric nervous system with hyperexcitability when you record from these enteric neurons and ultimately neurodegeneration. So I want to spend the last few minutes on talking about what the work that's done in my lab. Now, many years ago in 2008, when I actually came to Emory in 2003, and my interest was in the enteric nervous system, but it's very difficult to isolate these neurons from the intestine, whether it's a rat model, mouse model. So I wanted to have a tool or a mechanism of studying the enteric nervous system, not only from neurons isolated primarily from mice and rats, but also try to develop a cell line. So what we did was we took this mouse model, it's called an immortal mouse model. If you take any tissue from this mouse and you culture it under right conditions, the cell will continue to multiply and proliferate. So we isolated neurons from the intestine using a specific antibody. We were able to pull out these neurons and we created this cell line. This is the only cell line, enteric neuronal cell line that exists. And so far we've sent it to various groups across the world. Of course, this is a cell line, so we do have to validate our studies in human enteric neurons, which we are currently doing. So I just wanted to highlight that this is a tool we created in 2008. And then a little bit, I want to mention that work in my lab has looked at the effect of the gut microbiome on the enteric nervous system. This work is important in that it tells us that the gut microbiota can actually influence the nerves within the GI tract. This particular study looked at a TLR4 knockout model, a mouse model. As you may know, TLR4 is one of the receptors for a pathogen recognition receptor. So the gut microbiome, the gram-negative bacteria, their cell wall products can interact with TLR4. And what we showed in the study published in Gastroenterology was that when TLR4 is knocked out, there is a reduction in the number of enteric neurons, and there are changes in gastrointestinal motility, indicating the importance of the gut microbiome interaction with the enteric nervous system. We also went on to show that if you, prebiotics can actually influence the enteric nervous system and prevent apoptosis in the enteric neurons. This was a study where we looked specifically at the effect of a high-fat diet on enteric neurons and how prebiotics like oligofructosaccharide can help rescue the enteric neurons from dying, cell death. Again, another example to show an important influence of the gut microbiome on the ENS. We also demonstrated, this was a postdoc in my lab, Dr. Reichardt, and he showed how, depending on the number of enteric neurons in the gut, that can influence how your gut motility. And so a lot of what we do in the lab is study how enteric neurons survive. And ultimately, we want to understand how they influence the epithelial cells and immune cells through co-culture. This is a new method we are developing to assess the enteric nervous system in both human samples as well as rat and mouse tissue, where we use light sheet microscopy and a clearing method to actually look at the 3D view of the ENS, and we can quantify, and we're planning to do some AI related studies along with Dr. Anant Madabushi to assess the changes. And this is one place where we can, if we have colon cancer tissue from the surgeons, we can actually assess the enteric nervous system within that using this method. And finally, more recently, we've published in the JCI, looking at various methods of enteric neurodegeneration, a new method of cell death called pyroptosis, which is more of an inflammatory form of cell death. Again, we showed with a Western diet, there was influence on the enteric nerves. And so yes, I'll leave this at that. And this is the last slide I want to show in terms of the work in my lab. We're now studying the effect of iron accumulation within the enteric nervous system. And I included just this next slide to show the kind of primary cultures we can actually get from both mouse as well as human tissue, to which we can then study in culture to understand pathophysiology of the enteric nerves and how they influence cancer. So I want to stop here. I want to acknowledge some of the slides. The earlier ones were given to me by Dr. Azma Shaukat. She's at NYU, and Dr. Kulmira Nurgali. Everyone in my lab is at the VA hospital, and my funding as well as my collaborators. And thank you, and I will take any questions. Yes, please go ahead.
So, thank you for the great lecture. As I was listening to vagus nerve, I remember back in the day, the treatment for peptic ulcer disease used to be Digestion.
Yes, you're right.
And I was wondering if there's any data on what happens to those patients with regards to their cancer risk after they undergo Digestion.
Yeah, that's an excellent point. I actually don't know the data related to that, but I would, and we are still seeing the patients who had vagotomy and their, influence on peptic ulcer disease. So normally the vagus helps is like has this anti-inflammatory effect. And as I mentioned in one of the slides, they can potentiate, metastasis. So my hypothesis would be that maybe actually the patients would do better in the absence of the vagus, but I would have to go back and look for the data if any studies have been done on that, but that's a very good point.
How much, thank you for that.
Thank you.
How much does mouse work translate into human?
Yes.
They're that good, not so good.
Yes, I think, it's an excellent point, and that's why I think some of the studies that we do in mice, we definitely, try to see if the same pathways are in effect in humans. What I did not show today is we have now developed techniques to isolate from surgical samples the human enteric nervous system. So I think that's the next level. Even when we go to apply for funding, we're always being asked for the translational aspect. And so I think the reason to do it in mice models is to get an initial idea of how these interactions may happen. But you're absolutely right, down the road, we have to verify this in humans. And so maybe I'm not directly answering in terms of like a percentage, but it's maybe just the foundation or the beginning to then translate into humans. Mm-hmm. Thank you.
Based on your work, what do you think might be the best way to treat the nervous system? And then just a layering on that question, have you looked at how that impacts the nervous system?
Yeah, I think those are excellent points. And so I think when we think of treatment, we would have to look at, specific targets. So, the NDRG4, we saw, loss of that influences colon cancer. So having specific, antagonists, agonists in that region. So I think that's one aspect of the treatment of how the ENS, the biggest part is, I think, the neurotrophic factors and the neuroactive molecules. Can we inhibit them and prevent tumor growth? Or maybe even metastasis. This whole concept of, that the tumor cells are going along the ENS, I think the target would be receptors. That would be the best way to modulate it. Your second question was related to immune regulation. And there are some groups that are studying in co-culture the immune cells and neural cells, whether it's, extrinsic nerves like the vagal neurons, as well as the ENS and the interaction with immune cells. So I think there's more to come. This is just like an up and coming field, a little more interest. I want to mention one other thing in terms of this conduit theory. Some people believe, like, for example, in Parkinson's disease, it actually starts in the gut, in the ENS, and then there's the hypothesis that, then there's influence in the brain. Again, a sort of a gut-brain interaction. And so along those lines, I think this metastasis hypothesis is also slowly gaining importance. Yes, Greg?
Comment and a question. So
Yes.
first, thanks for all your work on research and continued integration with the GI oncology group of Winship. We're excited that there's a lot of collaborative things going forward, including the seminar led by Adam and others. So
Yes.
that's fabulous. And my question is related to your work on the prebiotics and how that influences really the carcinogenesis process. And do you think that it's most effective in sort of the prevention setting, or is there any application when the disease has sort of taken over and become a really advanced primary or even in metastatic setting? Will that have any sort of reverse effect and be modulated by microbes?
Yes, those are all excellent points. I think initially, probably in the prevention setting, I should sort of take a step back and say that prebiotics and probiotics, even in the GI motility disorders, the benefit is still not very well established. So I think extending it onto the cancer field, there's a lot more work to be done. But what I could envision is both in prevention, if we find the exact targets that we can, influence. So I think prevention would be one. It would be a sort of critical mechanism. But then down the road, if the microbiome, I think, influences the barrier function. So through that can actually probably influence both tumor growth and metastasis. So there's a lot more work to be done and how the gut microbiome influences all of these processes. So I think that's where the field is going as it relates to prebiotics and probiotics is trying to now even understand the basic metabolites and how, becoming very specific. So if we get down to that level, maybe we can actually influence tumor progression. Yes. Thank you.
So, can you talk a little bit about the biomarker and pre-exposed persons?
Yes. Yes, yes. I think so that's probably an area where the field is moving towards. The one thing that comes to mind is so these various neurotrophins like GDNF, BDNF, but whether they've been assessed to that level in terms of a biomarker, I'm not sure yet. The most work I think is done on the one study that I showed, the NDRG for the knockout mouse model. So I think that, as you know already, as a stool in the stool that's being used as a marker. So I think there's room for development of neural biomarkers. Yeah, and even actually as much as neuroactive, molecules within the stool, which could. So there's a lot more to be done in that field, but it's definitely a very nice thought and an area for development. Yes.
Very nice talk.
Thank
One
you.
of your slides, you showed that the neuronal system is sort of infiltrated, expanded with the tumor.
Yes.
Typically think of neurons as terminally differentiated. So I'm wondering, do the normal enteric nerve cells, what sort of proliferative capacity do they have, or regeneration capacity, and is it a tumor that's making the nerve cell expand, or how the interaction works?
Yes, yes, very, very good point. So there are stem cells within, the intestine that, for the enteric nerves. But there's also this trans differentiation between the glial cells. The support cells can actually become into neurons. So the glia to neuron transformation. But when I read and I was preparing for this talk, I think the tumor itself, the cells, they secrete neuroactive molecules that attract the nerve fibers. And I was reminded of the angiogenesis, sort of the vasculature coming into the, growing in the tumor environment. Similarly, the nerves seem to be doing that. And why that happens, and probably, so it's these molecules that are attracting it into the tumor. Yeah, I think,
Does the tumor need those nerves? Well, if you were to eliminate those factors that expand the glial cell into nerves, the tumor grows slower?
That's the theory. Yes, that because these neuroactive molecules, these neurotrophins, are making these adenomas and cancers larger. So that is the theory. Just like in angiogenesis, the VEGF and things like that, the NGF, BDNF, GDNF all seem to be making these epithelial cells proliferate. Now, I have to say there's not a lot of literature in this field. What I showed you is probably what's like most done. So there's a lot of work to be done, and we have the capability of doing this co-culture of the neurons and epithelial cells. So it's something we are thinking of in the future. We've not done any of this work yet, but also, in working with the colorectal surgeons here, we're able to get samples of tissue that we can then clear and look at the nervous system and see how it influences the epithelial cells.
Any other questions?
Yes.
This is for curiosity, but anorexia is such a prominent feature of these things. And we've always thought of it as evil humor, things that are just circulated. How much does this enteric nervous system play a role in anorexia?
I would say the gut-brain axis as such plays a big role in anorexia. And that's why I think, giving medications that can actually stimulate appetite, so through the central nervous system, can influence the anorexia. But you're right, it's the circulating, cytokines, things like that, that actually ultimately influence the appetite, resulting in kind of cachexia and weight loss. So the answer to your question, I think the ENS-CNS interaction is a big part of it. And, understanding that and modulating it can definitely help. What I didn't talk about was nausea with chemotherapy. That's a big, brain gut influence. And I think one final point that I'll make is when we think about the gut brain axis, and, stress is a big component of, we think can actually help predispose and enhance cancer. So where that influence can come from is actually in this gut brain axis. So the neurochemicals that are released due to stress can actually influence the cancer biology. And this gut-brain axis demonstrates one way within the GI tract that this is happening.
Anyway, you feel like angiogenesis has been the the subject of the day, but in all of our path reports, the perineural invasion is something we look at just again and again. It's a really fascinating area. Well, thank you all so much. Oh, sorry, Dave.
Yes.
I'm sorry, if we have time, I have another question if I may.
Sure.
One of the problems with screening is, of course, who's gonna do the colonoscopy? And so, to me, as a non-colonoscopist, it seems to me like this is something that should be teachable to people who aren't. And is there interest in doing that in gastroenterology?
So that's an interesting point. We live by doing colonoscopies we love. but I have to say, when I came here 20 years ago at the VA hospital, I was supervising APPs who were doing colonoscopies, and all over the country there are trained mid-level physicians that do colonoscopies. I think maybe a little bit broader answer to your question is the way we do colon cancer screening. So the FIT testing, the DNA testing in the stool, testing. I think that has to be implemented on a large scale. And then the positive ones get colonoscopies. That's a better kind of screening strategy. That's what we use at the VA hospital. That's what we're trying to implement at Grady. And, I think it's already at Grady, but, in using it to its maximum extent. But you're right, ultimately, we need a lot more people to do colonoscopy, which is why we encourage people to go into gastroenterology.
Yeah. Yeah, it's funny. I have a lot of faculty ask, well, do I need a colonoscopy? Maybe I just need a, FIT test or, a marker. And, I always sort of, say, if you're young and healthy, the value is in taking the adenomas out, which is not a cancer, which is not going to show up on a test. So, so it's as an endoscopist, I'll put in a plug for optical colonoscopy.
Yes, it has a 95% or greater sensitivity for looking for adenomas, and it's a lot of fun to do, and it's not too hard on the patient either. Yeah. Yes. Yes. Mm-hmm.
So, in the bottom, it's showing things of
That's a good question. So you're saying, can the ENS influence other cancers? Am I getting it right?
it's not so that is and things
Sort of connected. Mm-hmm.
So how about the work
I think so. I definitely think so, because I think, and the best example for that is under stress. We believe that long, term stress can influence oncogenesis in various organs. And there I feel the influence is actually the central nervous system in regulating the catecholamines release in various organs. So although I don't have a direct example for you, I truly believe that can influence, which is why I think, modulating stress long term can actually influence oncogenesis. Mm-hmm. Yes.
Sorry, since we get.
Sure.
When I grew up, there was a lot of talk about how Japanese have so much less colon cancer than people in the United States. But when people move from Japan to the United States, then they begin to get colon cancer.
Yes.
At the same rate. And that was always thought to be, when I grew up, diet.
Yes.
But of course, I guess it could be stress too. you know, for what you're saying.
Yes.
But is there thought about, you know, I don't think anyone ever convinced me exactly what in the diet was different. So there were a lot of theories, but could it be that whatever happens when you move from Japan to the United States is an effect on the entire nervous system? That's why you get more colon cancer.
I think for sure, you know, the diet plays a big role because the diet is different. Maybe there's more saturated fatty acids, less fiber. The other theory is that the gut microbiome changes based on the environment. So that's another influence. So diet, the microbiome, but definitely, you know, it's a different overall environment. Stress, you know, the stress levels are different. So the overall environment influence, I think, also plays a big role in you know, the development of cancer. How well that's been studied, I'm not sure, but in my own personal feeling is that all the factors together, if we can call them the environment of what these epithelial cells are experiencing, is different, and which is why there is more cancer. Mm-hmm.
Very good. We all need to chill out, right? All right.
Yes,
Well,
thank you.
Thank you so much. Thank you to Dr. Srinivasan for a wonderful lecture. Thank you for the invitation. Delighted to be a part, and we'll see you all soon.
Yes, yes. Thank you so much. Thank you, Matthew.
Yes.